Okay, so here we start to look at some of the treatments involving traction of the spine. So we're going to look at start just talking about the cervical and lumbar spine in general. So, when you're looking even at evaluation of the cervical and lumbar pain, the source of pain can be difficult to evaluate. There's a lot of structures. You'll see in the discussion that we're going to have here, there's plenty of structures that could kind of be the source of pain. Sometimes what people think is the source of pain really isn't. That's why sometimes MRIs could be deceiving. You got to kind of look at both MRIs and your clinical evaluation. So, the sources of pain could be the disc, the facet or the apophyseal joint, the soft tissue in the area, the nerve roots or the bony tissue could all be areas where there's pain. And, low back pain in particular is fairly common. Most, upwards to 80% of the population at some point will experience some type of lumbar spine pain. So, in looking at that, we look at traction as being one of the ways that we can utilize to treat this condition. So here, just for some anatomy, so you can look at the spine, you can kind of see, we talked about some of the involved areas with pain. So we obviously know that we have the disc could be an area of pain. You could have a herniated disc. In this case here, you're also involving the nerve root where the herniated disc is pushing into it. So the annulus fibrosus, which is the tough outer portion of the disc. You have the nucleus pulposus, which is the watery portion in the middle. Again, the idea is that annulus keeps all that material in there. That could tear, it could bulge in that case. Here you have the facet joints. So the facet joints are the back part in here in the spine, these plane joints of the spine. You could have some pain at the bony portion of the spine. So very common stress fractures of the pars interarticularis. So here you're just seeing kind of some of your anatomy of the spine and kind of some of the areas that can be involved with spinal injuries. So the disc many times gets kind of implicated and many times can be the cause of pain for somebody with lumbar spine pain. So you kind of look at what goes on with a herniated disc. So again, the disc has to move and shift to kind of help cushion the spine. It takes pressure off of the facet joints. So distraction relieves pressure on the disc. The idea is when you do traction, if you're dealing with a disc injury, is that you allow the disc material to retract back to the center. And then hopefully over time, you get a healing of that annulus fibrosis. So the disc is going to move as the spine moves. So, when the spine flexes, the disc has a tendency to migrate posteriorly. When it extends, it migrates anteriorly. Here's kind of what your disc injuries typically look like. So you have a disc degeneration where the disc just kind of breaks down. You have a prolapse. You can see the nucleus pulposus kind of coming through the annulus, but it's still kept within. There's still a part of the annulus still kind of holding it in, but it's deformed into it. An extrusion is when it actually comes through the annulus fibrosus, and a sequestration is when the disc actually will leak into the spinal canal. So the effects of traction, so essentially what you're looking to do is take either the lumbar or the cervical spine, and you're looking to lengthen it. So you're actually looking to get an increased space between the vertebrae. Now that's transient, obviously, meaning that once the tractioning is done, that means that the vertebrae will kind of go back to its resting position. But the idea is you get some of these other effects, and then hopefully long-term you relieve the issue. So it'll help increase circulation. It could stretch soft tissue, which again, you could get some muscle relaxation and spasm reduction from. The disc pressure changes. It could cause the disc to retract. And the idea would be maybe over time you could get some healing in the annulus through the different treatments. And then pain relief. And the pain relief would come from, some of these other effects that we discussed, whether that's the disc retracting and maybe it was putting pressure on a nerve root, or you're just relaxing the muscle and getting some spasm reduction. So now looking at the traction effects, we'll look at what traction does beneficially to all the different structures. First, if we're just looking at the bone, increase in bone density will occur through the result of traction, so you actually do make the bones a little thicker and stronger. As far as ligaments are concerned, you could decrease impingement problems or stretch the ligaments as need be. So many times the ligaments around the facet joints could sometimes get pinched inside the joint. You could decrease that impingement problem and also stimulate the proprioceptors and the ligaments to help reduce pain. Articular facet joints, you separate the joint surfaces and help the movement of fluid in the cartilage inside those joints. So again, the facet joints are those little processes on the back of the spine. It's one of the joints of the spine. As far as the muscles are concerned, it could help lengthen them, allow for better blood flow. And then with the nerves, again, I kind of made a mention of the stimulation of the proprioceptors and the ligaments, but the proprioceptors and all the soft tissues could get stimulated. They're those sensory nerve endings. And you could also potentially decompress nerves. So again, if you have for instance, in the case of a herniated disc impinging on a nerve root, that can help to decompress that and lessen the symptoms. So our traction techniques, we're going to be talking about both cervical and lumbar traction, and we'll be discussing the manual and mechanical versions of each one of those. Obviously, typically for mechanical traction, we're talking the use of a treatment table. However, there are other forms of traction that can be utilized without the use of the clinician's hands. We'll discuss sustained versus intermittent. So in the case of sustained, the traction is maintained for the length of the treatment. In the case of intermittent, there's going to be kind of a slight release in the amount of traction. There'll always be somewhat of a traction force, but it will decrease during the off time, if you will. And we'll talk about other forms of traction. We'll talk about over-the-door units and inversion tables and just ways that those can be utilized. So with manual traction, we'll start with discussing cervical manual traction. So the patient is going to lie supine. Typically what you're going to do is you'll position the neck based upon what area of the spine you're looking to affect. So if you're looking to affect the upper part of the spine, so the upper cervical vertebrae, you'll keep the neck in a neutral position. If you'd like to impact the lower cervical spine a little bit more, you would put the neck in slight flexion. And in the case of lateral relief, if you're looking to relieve the spinal nerves on one side, you can side bend to address that. The idea is to relax your hands and gradually increase your force. This can help to break the pain cycle. Of course, it's not going to structurally per se change the spine, but you can relieve pain and spasm with this, along with affecting those other tissues as we discussed. So for mechanical traction in the cervical spine, you could also decide to do continuous or intermittent with, I didn't say this with manual traction, but you can do continuous or intermittent. It's usually a lot easier manually to do intermittent. Very few people do continuous traction because it's hard to hold for a long period of time, so we'd use intermittent traction. When you're using mechanical traction, you could set the force. You want to keep it below 25 pounds. 25 pounds would be the most typically you're going to use on the cervical spine. You don't have to really worry about gauging that with your hands because you're likely not going to be able to pull, the head with more than 25 pounds of force. And I would say I have on here 20 to 30 minutes. You could be 10 to 30 minutes. 10-minute treatment is fine as well. So you can, mark that off and just put 10 to 30 minutes. And again, this can relieve pain from intervertebral disc herniation or stenosis. So when you're doing intermittent, you'll have an on or off time. So the starting point for intermittent, they look at 30 seconds on, 30 seconds off. If you know what your primary structure you want to treat is, they recommend slightly longer times, so upwards to 60 seconds for disc issues, and slightly shorter times, so like 15 seconds as far as the on time for facet joints. Okay, so facet joints will usually have a shorter on time. Disc issues will have a slightly longer on time. Again, 30 on, 30 off. If you're kind of not again, sometimes narrowing down the structure is a little tough. You can start with the 30 seconds on, 30 seconds off. Here are some different ways to kind of perform manual cervical traction. So you see here, now I don't really, this technique, you just got to be careful with, pulling up on the chin, you could possibly irritate the TMJ. I prefer either this where you're kind of just holding the base of the skull. Some individuals try this with the towel. Just watch, sometimes covering up the ears with the towel can be a little uncomfortable for the patient. You just want to make sure when you're doing this, you're kind of not digging into the back of the ear around the mastoid process with the thumbs, because that can be slightly uncomfortable. Here are some other devices. So here you're getting to see the mechanical traction here. So you would set this up. You would have this placed right at the base of the occiput of the skull. This is what's called an over-the-door unit. So you have to, obviously, in this case, you can actually put a little bit more than 25 pounds because you obviously have to account for the weight of the head when they're seated. So you have to make sure that you can kind of account for that with the over-the-door units, but even though they look a little strange, they're pretty popular to use. This is slightly newer here. This is what's called a pneumatic traction device. So what this is you can see she's got an air pump. So as she's pumping that, there's an air bladder that basically creates a tractioning effect on the spine, and you can actually get an alternating hydration and milking of the intervertebral discs as you let air in and out of that little region, so you can get that. So that's referred to as pneumatic traction, as you kind of move air in and out of that particular unit. Now, as we get into lumbar traction, so you can do manual single and double leg traction. So we're only showing single leg traction here. You can do double leg. Double leg manual traction is kind of difficult. You'll see why in lab what I mean by that. But one, you have to be able to hold both the patient's legs for the amount of time you're doing traction. This is the single leg variation. So with this, they just kind of recommend, again, it would be very difficult to do this sustained for a prolonged period of time, but this they just recommend 5 30-second bouts of traction. If you see the position that they put the hip in for this, so it's about 30 degrees abduction, around 30 degrees of flexion, a little bit of rotation, and they apply the traction force to the leg. If need be, you can have another person hold the patient down if there's nothing on the table. Most of the time I've found that I usually when I do traction, I don't have to have anyone else help. I could usually just do regular traction on a conventional table. Here's your mechanical lumbar traction. So you see them on the traction unit. One of the keys with this is you have to have as much skin-to-skin contact with the lumbar traction belt. So ideally for a male, they'll be shirtless. For a female, they should probably just be in a sports bra to facilitate as much skin to skin, because when that starts to pull, if there's any type of shirt there, it's going to pull on the shirt. So it is going to limit the amount of traction that you get. When you're looking at traction and positioning, so I'll talk more about like timing and everything later. The position you want to do for lumbar traction, so we said pretty much for the cervical traction, you're going to be doing either supine or you're going to be doing seated. You obviously can't really do a prone cervical traction. It's going to be kind of tough to do that because they're not going to be able to be face down on the table. So what you want to do is kind of determine what they're, again, if you can, as best you can through either diagnostic imaging or through your clinical assessment, determine what the potential cause could be. Now, again, a lot of different structures can possibly cause low back pain, but if you can narrow it down, you could position them with traction based upon what's wrong with them. Now, as far as positioning goes, I would just say this: you really want to position them based on the amount of what's comfortable for them. But typically, with people that have facet hypomobility and narrowed intervertebral foramen problems, Usually those are going to respond better to the patient being supine and in some flexion like you're seeing in this picture. Many times people with discogenic symptoms, so people that have symptoms related to disc herniation, they tend to respond better to being prone and being slightly extended. So naturally in a prone position, you'd have some slight extension. So in the end, you can go with what's most comfortable for the patient, but that is kind of a guideline to kind of at least have in the back of your mind when you're trying to decide how to position the patient for mechanical lumbar traction. So there are some other techniques for the low back, and I'm not going to get too in-depth into these. This is just what's called right here. This picture is called positional traction. So what they're actually doing with the patient here, so in all likelihood, their left side has some compression issues. So what they're actually doing is opening up the left side of the spine by kind of putting them in this right side lying position with this bolster underneath and having their hips positioned. So they're actually, and you could actually tell based upon how much you flex the hip and knee, like you could kind of even focus in a little bit more on one particular tractioning, one particular area of the spine. So that's called positional traction. You can also utilize the inversion table. So the inversion actually works really well. The biggest thing is the patient's tolerance to being upside down. Some patients can't tolerate being upside down for the time frame that they're in traction for. And typically what they suggest is build up to 3 sets of 5 minutes, and then you could then possibly extend the time. They also recommend, particularly if they have a disc issue, to have them kind of lay on their stomach and relax in a slightly extended posture upon finishing up the inversion treatment. So lumbar traction, again, you may relieve pressure on spinal nerves. Again, you'll still get all the other benefits we talked about in relation to the different tissues there. For a disc injury, again, typically you can have them lie prone. That would be your usual position for disc injury. But again, put them in a position of comfort. If you lie them prone, even if you're really certain they have a disc injury, if you lie them prone and they're not comfortable there, then it really doesn't make a whole lot of sense. Just put them in a position of comfort and do the treatment, but that would be your starting point. For the setup, again, you want the harness to be snug above the iliac crest. Again, if you could get it skin to skin, that's the best. And again, position the patient to release pain. As far as the force of the actual traction, you want to start at about 25% of the athlete's body weight, and you could work them up to 50% of the athlete's body weight. So up to 50%, that'll usually be enough tractioning. For some much larger individuals, you may be able to go, but 50% of body weight is usually going to be as high as you would go for an individual. But at a minimum, and you typically always want to start with the minimum. So I would start with 25% and just see how they respond. Same thing for overall treatment time. So treatment time, again, here can be 10 to 30 minutes. I would start with the least amount of time and see how they respond. If they respond well to 10 minutes of treatment, then I would stay there for a little bit. You can actually cause more problems by allowing traction to be done for too long a period of time. So particularly if they have a disc injury, if you do traction for too long, you can actually get the pressures to equalize, and the disc could actually herniate while they're in traction, and then when they come out, they'll actually have more pain. So it's actually better to go with kind of, again, the minimum effective dose. So, 10 minutes to start, and again, you could work upwards to 30. If you're seeing you're getting benefits at 10, you could kind of just stay there for a while. Same thing, intermittent or sustained. And the same rules for the on-off time would apply for lumbar as it would for cervical traction. Your indications for traction: disc injury, nerve root compression, joint hypomobility, muscle spasm, joint impingement. So we kind of alluded to these earlier in talking about the different structures that are actually impacted by the tractioning force. So again, you look at all the different structures we talked about, they're all addressed here in the indications. Your contraindications, so malignancy, so cancer in and around the spine, infection or respiratory disease, osteoporosis. If you have an acute sprain, so for instance, a torticollis or a Rhineck in the cervical region, you would not do traction for. If there's hypermobility, because think about it, you don't want to do, if there is hypermobility, you don't want to traction it because you're going to be making the hypermobility worse. Rheumatoid arthritis, any type of hypertension, cardiovascular disease, aortic aneurysm, and any type of increased pain associated with the traction. Now, these are specific for lumbar only. So pregnancy, hiatal or abdominal hernia, active peptic ulcers, and glaucoma for the inversion method. So you don't want somebody with a glaucoma doing inversion treatment. And again, these are just some more pictures. So here again, you see someone getting some mechanical cervical traction. So you can see that little pad right on the bed. You want this right tight to the occiput so that when it pulls, you're not getting any sliding. So this is a pretty snug fit in and around here. And again, here's where you would set all of your parameters: on, off, time, sustain, intermittent, how much force you want to apply, what have you. Here's your lumbar traction. So here you see kind of a setup. Now in the other picture, they were using like a little like bolster thing underneath the legs. You can just put them like this with the hips and knees flexed. Here's a prone position. Again, you know, I gave the structures and I want you to be aware of those and why you'd position them in one way versus another. But at the same time, again, if the patient just feels better being on their back, then that's just a better position for them. So know the different structures and why you would want to put one versus the other, but clinically, again, use clinical decision making, and if they feel better in a certain position, it doesn't worsen their symptoms, then certainly, you know, accommodate that.